Good day, I'm Dr. JB Alondo. This is part 6 of the Orthopedics module. We'll be discussing, we have discussed the review of the musculoskeletal system, orthopedic history, general orthopedics, and subspecialties. And in this lecture, we'll be discussing sports medicine and pediatrics. It's your pretest. So, sports medicine in orthopedics, it deals with the prevention and treatment of injuries related to sports and exercise, and they treat a broad spectrum of patients ranging from children to specialist care of professional athletes. So there are multiple factors leading to an increase in sports-related injuries. Basically, some athletes, they participate in one sport all year round. Even some weekend warriors that participate in sporting activities only in a few days in a month, and there's always an increased expectation for higher performance. Uh, there's been noted increase in sports injuries, particularly pre-COVID, and you have to consider the patient's attempted return to his or her previous level of activity, and rehab plays a major role. So, arthroscope is the basic surgical intervention for ligament and cartilage injuries in sports medicine patients. So, if you're not familiar with the arthroscope, it's we put a viewing camera inside the joint and some device, and we just use a TV camera. So it's very minimally invasive. It's like playing a video game. So you have your shoulder, you insert your small portals. You have your knee, you insert your very small portals, and as well as the hip. So for shoulder, we'll be discussing rotator cuff injuries, shoulder instability, your superior labrum and biceps tendon, impingement syndromes, and your acromioclavicular joint. So rotator cuff injuries basically are from forceful or repeated overhead and pulling movements. So if you can recall your rotator cuff by the mnemonic sits, it contributes to shoulder movement and glenohumeral joint stability. So in this particular image, this is an arthroscope. This viewing inside your shoulder joint is your glenoid, that's your humeral head. So you can see some separation already, some fraying of the ligaments here. So what we do, you see a ligamentous, this gap here, we try to close it with sutures. We are under arthroscopic repair. So shoulder instability, the patients basically with an anterior dislocation would present with pain and sternly rotated shoulder. And younger patients, as I mentioned, are susceptible to suffer from repeat dislocations than older patients. So the most common etiology is related to trauma, and the shoulder, as I mentioned, is stability is provided dynamically with the rotator cuff and statically by the shoulder capsular ligaments. So repeat dislocation. So we need to ask for your X-ray views. This is an example of an axillary view. This is an example of a Y view. So what we do is we do a Bankart repair. So there's a tear here. So we do repair. We suture it back in place. So this is the repair of the capsule and the labrum. And some would do some stabilization procedures. So next, your superior labrum and biceps tendon, or what we call a slap lesion. The labrum that acts as a stabilizer and attachment of your many of your muscles, particularly your biceps, the long head. So the shoulder, basically, it's the bony stability is not that good. So this the labrum would help stabilize the shoulder. And slap lesion basically means a superior labrum and an anterior and posterior lesion. Basically because of the pull of your biceps that causes your labrum to fray. Usually it is seen in throwing athletes or by those with repetitive shoulder motion, and they're characterized by shoulder pain and discomfort. X-ray is used to evaluate bony changes. So this is a type of your slap lesions. Some fraying already here. And if you compare to type 4, there's already the superior labrum has already come down with the biceps tendon. Usually with the MRI at the coronal view, you can see the slap lesion going down. There's already uh, the fraying of the labrum here. So if it's a type 1 injury, we can do some physical therapy and NSAIDs, even some steroid injection. And impingement syndromes, basically on the subacromial space, could range from simple bursitis to tendinitis or tear of your long head of the bicep or supraspinatus tendon. So usually the impingement occurs in maximum arm abduction and external rotation during the cocking and early acceleration phases of throwing. So basically, if conservative treatment does not relieve pain, surgery is recommended. What happens here is that the there's the bursa is inflamed because of chronic impingement to this area. So what we do is we excise that arthroscopically by bursectomy or acromioplasty. So the subacromial space, so this one is impinging on this side. So we have to do some sort of bursectomy and subacromial decompression. So we'll be discussing the acromioclavicular joint, which is a gliding synovial joint comprised of the lateral end of your clavicle and the medial facet of the acromion. So you have your three ligaments, the superior acromioclavicular ligament, the inferior, and the coracoclavicular ligament. Usually it's due to a lateral blow to the shoulder, and it's always prudent to request for a bilateral AP views so you can compare it with the other side. So in this case, you can see the normal relationship as compared to this one, where there's already this clavicle is somewhat going up as compared with if you compare the relationship to the acromion. So there's a classification system. The Rockwood classification basically measures displacement and reducibility. So type 1 to type 2, we usually treat with an arm sling and physical therapy. Type 3, if the patient is high demand or needs to use the upper extremity for work, so surgery is needed. 4, 5, 6 types usually need to do some sort of internal fixation with a ligament reconstruction. We go down to the knee, which is a pivotal hinge joint, the largest joint in the body, and it bears tremendous axial loads as well as torsional and shear forces. So the major stabilizers would be your ACL and your MCL, the menisci, the posterior lateral corner, and as well as your PCL and patellofemoral joint. Also helps in the stability of your knee joint. So for meniscus injury, the meniscus basically is a crescent-shaped piece of fiber cartilage that provides joint stability, shock absorption, load distribution, and proprioception to the knee. So It's a shock absorber basically. Creates usually happens on direct contact or twisting injuries, and patients would usually complain of pain, swelling, stiffness, catching, and locking of the knee. So X-rays usually to rule out any bone involvement. And this one, MRI, you can see some sort of tear on the meniscus. So small peripheral tears, usually we just treat conservatively. But this time, if you can see this one, this quite a large tear going to the crossing. This is the whole meniscus. This one is crossing and lifting the meniscus actually off the edge. So this one you have to repair. In some cases, if it's too big, uh, we do a meniscal excision. So collateral ligaments are the most frequently injured knee ligaments, particularly your MCL, uh, usually from a valgus stress or a lateral blow, and patients would complain of a pop. So if there was an unhappy triad, if a terrible triad of the elbow, there's also an unhappy triad of the knee. It's basically an MCL injury, a meniscus injury, as well as an ACL tear. So we check this by using valgus stress test in 30 degrees flexion. And an MRI, you can see a disruption of your MCL. And this part, there's separation of the MCL. So Houston classification is just basically mild, moderate, or severe, depending on the endpoint of your stress test. Cruciate ligaments, they provide anterior and posterior stability of the knee. So ACL is most commonly injured. So this happens when there's a twisting injury. ACL is a common sports injury basically involving stopping and cutting sports. So this alters your knee biomechanics and kinematics. So usually patients with ACL, they would develop early degenerative changes if it's not addressed. So patients complain of pain, swelling, instability, loss of range of motion, and joint-like tenderness if there's a meniscus injury. Commonly, they would say that it's giving way while walking down the stairs. And Lachman's test is the most sensitive test you can use in your PE. And an MRI, you can see a complete tear of your ACL as well as bone bruising. And it's important to note that cruciate ligaments, they do not heal on its own. That's why you have to do an ACL reconstruction. So this one, you can see a tear. The posterior lateral corner basically is composed of your lateral collateral ligaments, your popliteus tendon, and popliteofibular ligaments. They contribute to the static and dynamic stability of the knee, and usually they are in combination with your cruciate ligament injuries. The PCL more common than the ACL. So again, they alter your knee biomechanics, so they increase the stress on your surrounding stabilizing structures. Need to see on MRI, you can see this the separation from your and some edema as well. If it's high grade, then you need to do some surgery and repair or even reconstruction. So the last topic for sports is the hip femoral acetabular impingement or the FAI. Basically, it's an impingement of the anterior femoral head-neck junction against the acetabular labrum. So if you abduct, it's causing this part to abut against it. So usually there's excess bone at the head-neck junction causing some pain. So this could be divided into your cam or pincer lesion. Cam lesion basically there's usually a offset at the femoral head-neck junction. On the other hand, your pincer lesion is normal acetabular version. So there's some excess bone coverage in your acetabulum causing the impingement. So this could lead to labral tears, cartilage delamination, and if untreated, could cause osteoarthritis quite early. So patients would complain of groin pain with hip flexion, and on impingement tests, you have limitations of flexion, adduction, and internal rotation of the hip. And X-ray, you would see some bony lesion, and MRI and CT scan to see some acetabular overgrowth here. So options are for surgery with acetabuloplasty, arthroscopic removal of those bumps, or a combined approach, either arthroscopy with open surgery. So this is the second part of this lecture. We'll be dealing with pediatric orthopedics. So this is my subspecialty. I trained. This is the team I trained with in Singapore. So basically, we deal with birth injuries, particularly brachial plexus injuries, cerebral palsy, pediatric fractures, as well as developmental disease. So birth injuries, particularly brachial plexus injuries, they occur in around 2 births in every 1,000. They're particularly related to large birth weight, forceps delivery, breech presentation, or a prolonged second stage of labor with shoulder dystocia. So I think you just finished your OB module. You should be quite familiar with this one. Basically, this is a stretch injury of the upper or lower plexus. So an upper plexus injury, or called the herb Duchenne, basically you have weakness of the shoulder abductors and external rotators as well as the elbow flexors. So the hand is not involved. If this is the case, the hand is not involved, the patient is able to move the hand, that has good prognosis. So the classic term for this is called the waiter's tip. So waiter's tip because they say, if you can remember the Snell drawing, you put your tip that on the waiter as behind his back. So, but we have to take note that Horner syndrome is which consists of ptosis, meiosis, anhidrosis, and ectothalamus, which indicates preganglionic injury of your cervical sympathetic nerve. If this happens, as with this brachial plexus injury, this would mean a poor prognosis. So treatment would be passive range of motion exercises. You have to ask the parents to move the extremity. Our target is that 3 months of age, the patient should be able to move it. If by 3 months of age, we might need to do some neurolysis, nerve transfer, or some nerve grafts. So cerebral palsy basically is injury to the brain, which may be associated with mental impairment. So cerebral palsy could happen during pregnancy, during the birth procedure, or even after or postnatal. Spastic is the most common, which means that there's increased muscle tone and hyperreflexia, and it's usually the most amenable to operative treatments. Athetoid usually is characterized by constant succession of slow breathing, involuntary movements, while ataxic is characterized by inability to coordinate muscle movements, resulting in unbalanced and wide base gait. And there's also a mixed type. There's also anatomic classification as quadriplegic, involving total body involvement, and non-ambulatory, diplegic, mostly the legs, and hemiplegic, usually one side of the body. So as I mentioned, it's most common spastic hyperreflexia with increased muscle tone. So what's important is to work with an early intervention with the physical therapist Our aim here is to prevent contractures, and basically our surgical treatment are for contractures and soft tissue releases. So if we have to watch out for hip dislocation or subluxations, and if this happens, we could do some hip flexor adductor release, osteotomies if older, and for knee flexion contractures, some hamstring lengthening or knee brace. For foot deformity, usually shoe wears, modification could address the problem, but in cases with equinovalgus, we tend to do some tendon releases. So, pediatric fractures. Basically, the pediatric skeleton, it's less dense, has lower bending strength, periosteum is very thick, you have your growth plates, the tendons tend to be stronger than bones, especially in adolescents. The composite of physis, you have your serve zone, the zone of proliferation, and this physis is actually a weak point, and fractures in this area could lead to growth arrest and angular deformities. And for diagnosis, it's important, if you're in doubt, you always do an x-ray of the contralateral limb. So growth plate injuries. So Salter-Harris classification. So in your textbook, in that particular chapter, it's quite uh, toxic to memorize, but it's good to know that Salter-Harris, there's a mnemonic for that, the Salter. So type 1 is straight across, so separation. If this one is above. Type 3 is low or below the epiphysis, through the epiphysis. T for through, going through epiphysis, then to your metaphysis. And R or erasure or crush, R. So the treatment for this is the atomic reduction of the fragments. Usually we treat this with smooth wires, and the problem usually are complications with leg length discrepancy and angular deformities. So diaphyseal fractures, basically in children there's more angulation and shortening is tolerated compared to adults, and there's high potential for extensive remodeling. Diaphyseal fractures in children basically is treated with a close reduction in a cast because of the remodeling potential. It's also important to note that older children, they have lesser remodeling potential. So if adolescents, usually we need to do some sort of surgery. So forearm fractures, basically we can 10 degrees of angulation and rotation is quite acceptable. And it's also important to note that in children, there's what we call a plastic deformation. There's no break, but there's already plastic deformation of your bone. So this is quite needs to be uh, surgery needs to be done. We have to break this one and put a implant. No? For forearm fractures, we put an elastic nail to help them. This is a titanium nail that we put intramedullary. Femoral fractures, the treatment would depend on age. But if important thing to note with femoral fractures is that if there's a incidence of a femoral fracture before walking age, there's most likely uh, you have to consider child abuse. So again, as I mentioned, treatment depends on age. So less than 6 months, we can put a Pavlik harness. So femoral fractures, can use this also an elastic nail, and 6 months we can use a Pavlik harness, or we can use a spike cast with 6 months to 5 years. And here, 5 to 10 years old, you can use an elastic nail. And if it's quite bigger patients, older patients, we could use a plate. Continuing with pediatric fractures. So for pediatric hips, usually there's due to high energy trauma and weak bone, we usually just put a spica cast. Pediatric ankle, this is also the Salter-Harris classification. It's important to note it's almost the same. Separation above, uh, low through, crushing. Uh, the Tilao fracture is basically a type 3 fracture involving the medial malleolus and avulsion of the tibiofibular ligament. So basically, it's a it happened to a weak structure, so you have this one needs to be fixed. Triplane fractures are complex fractures in older adults, and they result this one type 2 result in partial closure of the growth plate. So this could lead to some angular deformities. So pediatric elbow, you have your supracondylar fractures. You can either have supracondylar, lateral condyle, or medial epicondylar fractures. So treatment basically is you use smooth pins or wires. Next is your developmental dysplasia of the hip. Basically, this ranges from dysplasia, subluxation to outright dislocation. So this is an X-ray of comparing the normal hip, same patient with a dislocated hip. So basically, the firstborn females with a positive family history breach has a high incidence of DDH. So we need to check for hip instability within the first 72 hours. So basically, we need to do a Barlow and Ortolani test. So Barlow test basically is to dislocate the dislocatable hip or click of exit. Then Ortolani, basically you try to reduce a dislocated hip by elevation and abduction of flex femur or click of entry. So Barlow again, you try to dislocate a dislocatable hip, while Ortolani you reduce a dislocated hip. And there's also the Galeazzi test where you can see a parent limb length discrepancy because of a dislocation of the hip. So on x-rays in older patients, particularly more than 4 months of age, you can ask for this x-rays and you can plot these lines to check. Usually the femoral head is around this area. If we plot this line, the femoral head should be around this acetabulum. If we can observe, the acetabulum is quite shallow, so this should be around this area as compared to this one. Okay, that's why if you want to see further, the hip ultrasound is also requested. You can see the relationship of the femoral head to the labrum as well as your acetabulum. The goals of treatment in DDH is to achieve stable concentric reduction of the hip. So in neonate and up to 6 months, we can use a Pavlik harness. 6 months to 18 months, we can use a spica cast. And more than 18 months, if there's still some degree of dislocation, we may need to do some femoral and acetabular osteotomies. So in this case, we did a femoral osteotomy to help rotate the head back into the acetabullum. We did some acetabular osteotomies to help contain this head. Leg calvertis disease or LCP is the idiopathic osteonecrosis of the proximal femoral epiphysis, usually occurring between 4 and 8 years of age in males. If you can see this part, there's already osteonecrosis of the proximal femoral epiphysis as compared to this one. There's actually levels classification system based on the fragmentation of the femoral head. This is common in those with family history, low birth weights, abnormal birth presentation, Asian, Inuit, and Central European descents. Patients would actually come in with groin or knee pain, decreased hip motion, or even with a limp. And usually do an x-ray of AT and frog leg. Uh, Presentation of less than 6 years is a good prognostic indicator. What we basically do is just give pain relief, do range of motion, and make sure that the hip does not dislocate. Another is the slip capital femoral epiphysis. If you can see this condition where the slippage of your head in relation epiphysis compared to your metaphysis. This one you can see the relationship. So this one happens, the slippage is through the hypertrophic zone, usually in adolescent obese males, even in those with children with endocrine disorders or Down syndrome. Basically, they complain with groin or thigh pain, limp, or sometimes knee pain. Uh, Diagnostics are x-rays. This is a frog leg view. In some cases where it's not evident, you can ask for an MRI. Treatment basically is percutaneous in situ fixation. So in situ meaning we don't have to reduce this one. You don't have to open. You just need to do a small incision and put a screw in. If you catch it too late, then you have to do some osteochondroplasty and some proximal femoral osteotomies. So lower extremity rotational abnormalities. Basically, their book mentions in towing. So you have either femoral anteversion, tibial torsion, or metatarsus adductus. So the problem could be in the femur, in the tibia, or in the foot. Usual in towing is normally it's normal in 3 to 5 years of age. If you have young children, you can observe they have some degree of in towing around 3 to 5 years of age, and usually correct by around age 8. So femoral anteversion, usually the parents or the would complain of an in-towing gait, and one particular sign is your W sitting. They resolve spontaneously by age 8 to 10, and they rarely need surgery. Another cause is tibial torsion in toddlers. This is the most common cause of in-towing. It resolves spontaneously by age 4 and rarely needs surgery. Metatarsus adductus basically is adduction of the forefoot at the tarsometatarsal joint with normal hindfoot alignment. So as point here, as you can see, it is a prominence of the crease. So in towing could either be of three. This metatarsal adductus also resolves by around age 4. Next condition is the congenital Talipes equinovirus or the clubfoot. So the muscle contractures are contribute to the equinus virus cavus and adduction position, or our mnemonic is cave. So adductus of the forefoot due to the tight tibialis posterior, virus due to the tight tendon of Achilles tibialis posterior, and equinus basically due to the tight tendon of Achilles. It is an idiopathic condition, but genetics is highly suggested. We don't usually need x-ray, but we request for x-ray in some cases where we do some Ponseti reduction and there's still some problems. So treatment, as I mentioned, Ponseti, It's a serial cast manipulation followed by tenotomy and Denny Brown brace. So Ponseti revolutionized the treatment for clubfoot. Before he came around, clubfoot was basically treated surgically. But because of Ponseti, we do a serial casting. So this is a stage one. We try to gentle manipulate, change the cast every month, and you see a gradual correction of the equinovirus. And at the end of when you reach at this age, this range, we do a tenotomy and put in a Denny Brown brace. So it's somewhat like putting your toddler in a skateboard. So I tell my patients, the parents, that we'll be buying him a skateboard early than expected. And for those severe cases, we need surgery. We do posterior medial release and tendon lengthening. So this is the last topic for this lecture. Osgood-Schlatter disease basically is a traction apophysitis of the tibial tubercle. Usually occurs in adolescent boys in jumping and sprinting sports. So there's pain on the anterior knee, particularly when they kneel. So this, as you can see in the X-ray, you can see there's some ossification already. The ossiculus, there's some ossification. This is actually where the tendon of patellar tendon would attach. So what happens is there's a constant pull um, from the tibial tubercle causing pain. So treatment usually activity restriction and anti-inflammatory drugs. Some they can do cast immobilization, and some refractory cases we do ossicle excision, especially in skeletally mature patients already. So we've discussed general orthopedics, trauma, sports, and pediatrics. Spine and tumor will be discussed by another lecturer. This is your post-test. Thank you and hope you enjoy our module on orthopedics.